Dr. A.K. Dewan with Indian Army Medical Services. He is actively participated in the Kashmir operations of the army during 1946-47. In 1950, he proceeded to England to pursue MRCP. On returning, he joined Lucknow Medical College. Later, he also served at Kanpur Medical College, and finally in 1963 he was sent to Allahabad Medical College as the head of the Department of Medicine. In a short span of time, he rose to be the director, professor and head of the Department of Medicine at MLN Medical College, Allahabad. Two most prestigious awards of the field, Dr. B.C. Roy National Award for Outstanding Contribution to the Medicine and Hari Om Ashram Award for Research, have been conferred on him by the Medical Council of India. He has had an abiding interest in rheumatic fever and rheumatic heart disease and has done much work on the area which is presented in his book Rheumatic Fever and Rheumatic Disease in Developing Countries. He had the honor to be distinguished speaker in international conferences at London, Tokyo, Washington, Bangkok, Taiwan and Kuala Lumpur. After retirement, he was designed as the Emeritus Professor of Medicine by the UP government. He continued treating patients after retirement and ran a polyclinic at RK Mission where he provided medical services to the poor free of cost. And this oration has been given to Dr. A.K. Dewan. May I call Dr. A.K. Dewan, sir, please.
I would request Kamal sir to invite a speaker for this esteemed oration.
Good afternoon to all of you. Thanks to organizer of AMACON for giving me this opportunity. Dr. Dewan is my teacher, my Guruji and my source of inspiration. I have been trained under him and I still take his advice in different difficult and challenging situations. Today, I feel privileged and honored. Dr. Dewan does not need any introduction. Everybody knows him very well. It is customary, so I do. Dr. Dewan is Director, Surgical Oncology at Rajiv Gandhi Cancer Institute, Delhi. He is a graduate of Maulana Azad Medical College, Delhi, postgraduate from Ram Manohar Lohia Hospital, Delhi University. He had his past doctoral education from Cancer Institute, ADR, Chennai. His area of special interest is head and neck cancer surgery. He has been the former medical director of prestigious Cancer Institute, Rajiv Gandhi Cancer Institute till 2017. He is credited with standing DNB courses in surgical oncology, gynae oncology, fellowship program and now FNB program in head and neck oncology. He is also medical director of philanthropist organization Ganga Prem Hospice based in Raiwala, Uttarakhand. This is a palliative care center for terminally ill cancer patients. They have very strong home care program where terminally ill cancer patients are seen and served at home in Rishikesh, Haridwar and Dehradun area. I salute Dr. Dewan for his sincerity, discipline and social work in addition to his professional commitment. Over to you, sir.
Respected chairpersons, many of the senior faculty members, family members of Dr. B.L. Agarwal family, friends, ladies and gentlemen, I am honored to deliver this oration. My special thanks to Dr. Kamal Singh. बड़ी खुशी होती है जब बेटा बाप से आगे निकल जाए या चेला जो है गुरु से आगे निकल जाए। I will only say, Kamal, keep it up and maintain the glory of AMA, which is culturally rich organization. Special thanks to Dr. Anubha also. 1.5 months back, she said that, sir, आपको कैंसर सर्वाइवल के बारे में बोलना है. मैंने कहा, दिस इज अ वेरी टेक्निकल टॉपिक, मीन्स so many graphs to be shown, so much literature to be talked about. She said, you have to speak from the core of your heart. Don't talk of literature. I said, fine. Let me plan it. Then I discussed with Dr. Kamal. And before I actually start the talk, I'll quote few words from Gulzar. मेरी लिखी बात का हर कोई समझ नहीं पाता, मेरी हर लिखी बात को समझ नहीं पाता, क्योंकि मैं एहसास लिखता हूँ और लोग अल्फाज पढ़ते हैं. तो कृपा करके एहसास करिए मेरी बातों का और अल्फाजों पर कम जाइएगा. I remember my graduation days in 70s when cancer was a curiosity. We used to see patients in this stage, all the fungating growths, और सारे स्टूडेंट्स भागते थे क्लास में कि कैंसर दिखता कैसा है. And everybody used to have surgery if patient got admitted under the care of a surgeon, and then she was discharged, not bothering about what is the outcome. कोई problem हो तो आ जाइएगा, otherwise if any hospital had radiotherapy department, she was referred to the radiotherapy department. But things have changed now. We talk of early detection and virtual cures. The other thing which was there in those days was we only had plain X-rays, IVPs, and even ultrasound had come in late 70s. And our teachers used to say hand scan is best scan. And I still say that that is the best scan you ever have, which is rarely used. But now we depend on PET scan and CT scans and MRIs. We treated cancer with either surgery or radiation. Drugs were hardly there at that time. And nowadays the focus is on combined modality treatment. Surgery used to be quite mutilating, and we only had cobalt machines. And now we talk of robotic surgeries and IGRTs and targeted therapies and immunotherapies. And survival was quite poor. In late 90s, there was a publication from Rohtak Medical College. A radiation oncologist had written there, the follow-up was 15% only. 15% of the patients came for follow-up. For a good follow-up, there could be only dropout of 15%, but 85% should be followed up. But at that time, just 15% follow-up, and the cure rates reported were less than 7%. And the data he had collected was from 1982 to 1991. And the 10-year survival he had quoted was 0.2%. The outcome was so dismal. And nowadays we talk of cures and we talk of quality of life issues. So what is actually changing? Is survival really improving? The practice of oncology is actually changing. It is changing from unimodal to multimodal. It's basically total care of patients by combining various methods of treatment by multi-professional team with intent of cure or palliation. It is a team approach. आज मैं ये नहीं कह सकता कि मैंने सर्जरी कर दी है और तुम जाओ और बस हो गया काम. That is not the attitude. Aim should be how can we improve the survival of this patient. You see, India is not lagging behind in technology. आज robotic surgery या proton therapy बाहर आ गई तो within 5 years you see it in India. But problem is non-uniform development in various parts of India. And various people, various strata of people don't get the benefit. The other change which is coming up is, you see, we were low technology previously, but we were high tech. We were low tech and high touch. मरीज को एग्जामिन करते थे, हाथ लगाते थे. आज उसका उल्टा होता जा रहा है. We are becoming high tech but low touch. आज की यंगर जनरेशन मरीज को हाथ नहीं लगाना चाहती है, एक्सरे भी नहीं देखते हैं, वो रिपोर्ट पढ़ते हैं और वो भी कंक्लूजन पढ़ेंगे और ट्रीटमेंट स्टार्ट हो जाती है. That is for the worst which is happening with the younger generation, and we are talking of survival here. Before we actually go into the survival, what is survival and what is mortality? There is a very thin line between survival and mortality. Either the person is alive or dead. Mortality means it measures the number of cancer deaths amongst the entire population. People with or without cancer. The total population is taken into account. That is mortality. Usually measured in 1 year. How many deaths in 1 year? Survival is the numbers alive among people with cancer. Usually taken as 5 year is the yardstick. It is the chance that a cancer patient will be alive 5 years after diagnosis. That is survival. There are various definitions of survival. I am not going to into the detail of those. Overall survival, cancer prognosis, relative survival, net survival, disease specific survival. So, without going into the details, but most important here for a lay person is cancer prognosis and overall survival. Overall survival means alive 5 years after diagnosis, divided by total number of that particular cancer patients. And if you remove the competing causes of death, that is actually the cancer prognosis. Patient यही जानना चाहता था मेरा कितना % चांस है कि मैं 5 साल के बाद जिंदा रहूंगा. That is the prognosis of a particular cancer for a particular patient. So what has affected this cancer survival? It's logical to think what is the type of cancer, what is the stage of cancer, and most important is biology of disease. Biology is the king. Facilities are pyadas only. Any aggressive tumor, even if it is stage 1 disease, may kill the patient within months' time. Next is prevalence of screening facilities. Next is availability of treatment and affordability of treatment. Accessibility. People can access the cancer facility or not. Is it affordable to the people or not? I will go into the details of accessibility and affordability. These are main issues in India. Why we have poor survivals in India. Some figures. Globocan actually gives you annual data on the incidence mortality of cancer. According to Globocan, in 2020, there were 2 crore patients in India, in world, not India, world. And on top, 11.7% constituted by breast, 11.4% lung, colorectal is 10%, and cervix is only 3.1%, which is our problem in India, not in the Western world. Mortality is maximum in lung cancer, 18%, then colorectal is 9.4%, breast is 6.9%. If you chart it together, the incidence and mortality, Australia has the maximum incidence of cancer but the least mortality. Incidence is about 450 patients per lakh population and the mortality is 80. And then come New Zealand, Ireland, Denmark, US and other countries. According to one of the older studies, there was some population-based study of 7 high-income countries where they had taken 3.76 million cases and they had shown from 1995 to 2014 there was consistent improvement in cancer survival for most of the cancers. And the survival had improved because of early diagnosis, tailored treatment, policy reforms within the country, and improved care pathways. I'll come to that, what is care pathways. And substantial progress had been made in cancers of stomach, colon, lung, ovarian cancer in these countries. And cancer survival was generally higher in Australia, Canada and Norway, followed by US. So if you see what made these changes, they had given few examples. Say rectal cancer, the net survival improved because of better surgical techniques when TME came. Pre-operative radiotherapy was started. So the survival improved from 9% to 21% only. It had never reached beyond 50%. The molecular markers started being used. Targeted therapies came. PET scan was being used for better planning and staging. So it was seen, this one figure, in US, there has been 33% decline in death rate in last 30 years because of cancer research, anti-tobacco efforts, screening strategies and HPV vaccine. And till 1991, the incidence of 215 per lakh dropped to 144 per lakh in 2020. As I said, early detection and screening made a change. So what was that change? See, the early detection of cancer led to decreased morbidity and improved survival. You detect it early, more people will live longer, survival will be better, say mammography between the age of 50 to 70 years of age and colonoscopy in healthy population over the age of 50 years made lot of difference. Early detection and high chances of cure. Then strong family history of cancer, if it is there, you do an MRI for women in mid-20s and you find BRCA mutations and you do prophylactic surgeries, you can virtually save lives. The future of this early detection, which is coming up in a big way, is circulating tumor cells. Do a simple blood test, find out the circulating tumor cells and circulating tumor DNAs. I think these are all novel genomic therapy approaches to detect cancer early. Just doing a simple blood test, detect it early, even if it is not manifested anywhere in the body, and you can virtually cure these cancers. But that is the future. So, how screening is making a difference in survival? For cancers that are amenable to screening, like breast cancer, colorectal cancer, even childhood cancers, you see, it is seen that in US, Australia, the breast cancer survivals had reached 90%. Countries like Malaysia, it is 65-60%. Where there is no screening, like lung cancer, high mortality, liver cancers, there is hardly any screening, pancreatic cancer, wherever there is no screening and less effective treatments are available, survival variations are not there. Survivals have not improved, whether it is America or England or any country. But there are cancers where the survival is even otherwise very high. That is thyroid cancer, prostate cancer, testicular cancer. So wherever you go, geography will not help. Now, if you see where do we stand, cancer scenario in India, we have about 15 lakh new cases every year in India. And primary prevention is possible in 50% of the males in head and neck cancers, GI and lung cancers. In females, they cannot be primarily prevented, but screen detected. Early screening is possible in breast cancer and cervical cancer. But unfortunately, in head and neck cancer in India, the growth rate is 23%. Prostate cancer 19%, ovarian cancer 11%, breast cancer 8%. 60% cancers can be prevented. So India's cancer graph actually tells you two things. First is story of hope, that the incidence is very low. If you see Denmark, US, it is 300 per 1 lakh population, that is the incidence. India has only 80 to 100 per lakh population, which is hardly 1/3 of what the Western world has. But the second story is worrisome, poor survival in India. That is 30% now. 30 years back, it was just less than 5%. Now it is 30% survival in India, while the Western world sees more than 60%. So we are 30% lower than the Western world. The cancer survival rates, I'm just repeating, are the lowest in the world. There has been a massive study. They will otherwise have a good survival. depending on stage rather than geography. So, what is driving cancer death rate down, especially the Western world? We are progressing, but the progress is slow. Screening and early detection. These are key words. We hardly have any screening, rather no screening, and hardly any attempt on early detections. There has been a revolution in treatment of different type of cancers. Here I have taken an example of lung cancer. Means मुझे मालूम है कि जब से मैंने अपना कैंसर सर्जरी का कैरियर स्टार्ट किया उससे पहले we had never seen lung cancer person surviving more than 1 year rather. But nowadays we see good survival beyond 5 years with targeted therapies. So we have good chemotherapy drugs, targeted therapies, immunotherapies, precision radiotherapy, and good surgical techniques. So less than 30% of cancer patients survive 5 years after diagnosis. North America, West Europe, the overall survival of all cancers is 60%. So we are just half. Why we are half? The reasons: delayed diagnosis, inadequate, incorrect or suboptimal treatment. वैद भी यहाँ ट्रीट करते हैं भैया, सभी लोग ट्रीट करते हैं, कैंसर स्पेशलिस्ट तो सारे ही अपने आप को मानते हैं. पुअर एक्सेसिबिलिटी, पुअर अफोर्डेबिलिटी, the lack of awareness, and there are no screening programs. 92% of patients from rural area first consult general practitioners, and 79 of whom are not qualified to treat any disease, leave aside cancer. So people will go to RMPs and quacks, and there's misinformation, absence of knowledge, and low trust in public sector. So what are the problems in India? Why we are lagging behind? People say we have volumes, population is so much. Some people might think it is a problem, but I think it is an opportunity. More than 50% of our people are lost to follow-up. Of course, there is disability, deformity attached to disease and treatment. Infrastructure not available everywhere, not affordable to everyone. There is lack of training. I remember I had never done some major head and neck surgery in my post-graduation days. I had never seen oral cancer surgery. And it was only after my post-graduation I got interested in head and neck surgery, went for MCH and did all that. There is urban concentration of all the facilities. There are no uniform protocols. There is non-compliance. Even if you make a protocol, nobody follows it. वो जो मैं कह रहा हूँ वही ठीक है. That is the best I will provide to my patients. There is lack of awareness. The data reporting is not there. We have 27 cancer registries which are population based, but it covers only 59 lakh population of India. That is 0.5%, less than 0.5% of population. So we don't have exact data of how much cancer patients do we have. And every year 9.6 lakh, approximately 10 lakh people die from cancer, and 70% of these deaths occur in lower socio-economic strata. इंडिया में दूसरी प्रॉब्लम है ऑल्टरनेटिव थेरेपी की. क्वैक्स भी ट्रीट करते हैं, होम्योपैथी, आयुर्वेदी, यूनानी, you name any pathy, they will be expert in treating cancer. I see so many patients. Patient comes to me, stage 1 CA breast. I tell them you need surgery. She says she'll come after 2 months. She will have alternative therapy for 4 months. The growth will fungate. And वैद साहब ने उसको कहा ये जो ऊपर ऊपर बाहर निकल आया ना, ये कटवा लो डॉक्टर दीवान से, हमारे पास आ जाना, हम क्योर कर देंगे इसको, बाकी को अंदर वाले को हम ठीक कर देंगे. आई से आई कांट ट्रीट यू नाउ, यू नीड कीमोथेरेपी. वो डॉक्टर के पास जाती है, वो कहती है, वो डॉक्टर साहब कहते हैं कि देखा मना कर दिया ना, नहीं कर सकते कुछ, वो इलाज उनके पास नहीं है. सी दैट इज द लेवल ऑफ कॉन्फिडेंस पीपल हैव इन ऑल्टरनेटिव थेरेपीज. Then something which I have coined the term superlative therapy. I'm not saying, I'm not averse to alternative therapies. Alternative therapies are good. Homeopathy, Ayurveda, but they cannot be a substitute for the conventional treatment. They can be additive. The other thing, I'll explain what is superlative therapy. The concept of my patient, ये हमारे एलोपैथी मेडिसिन में भी बड़ा ज़्यादा है. होम ये चाहे वो रेडियोथेरेपिस्ट हों, सर्जन हों, मेडिकल ऑन्कोलॉजिस्ट हों, या कुछ भी थेरेपी के एक्सपर्ट हों, कि मेरे पास पेशेंट आया है तो मैं ट्रीट करूँगा, मेरी ट्रीटमेंट सबसे बेटर है, बेस्ट है. चाहे पेशेंट को सर्जरी चाहिए, अगर वो मेडिकल ऑन्कोलॉजिस्ट के पास पहुँच गया तो वो सर्जन के पास नहीं पहुँचने देगा. ओरल कैंसर को कीमोथेरेपी मिलती रहेगी, 6 महीने तक कीमोथेरेपी मिलती रहेगी, टिल द टाइम इट बिकम्स रेजिस्टेंट. सेम इज ट्रू विथ सर्जन्स. Even if it is unresectable, he will try to use the knife, even if not indicated. I'm sorry, I'm a surgeon, but still I'm talking like this. Because we must end this concept of my patient. मेरा patient नहीं है यार. The patient is our patient.
Please, sir, continue, sir. Please keep quiet.
See, these things are rampant in India. Even cancer being treated like this, jhada. For various reasons, even cancer being treated like this. Can you beat it? Next दिखाना. नहीं, ये देखकर हमें हंसी जरूर आ रही है, बट दीज आर रियलिटीज ऑफ लाइफ, व्हाट इज एक्चुअली हैपनिंग एट ग्राउंड लेवल. नहीं, क्या लगा दिया, वो स्लाइड लगा दो जहाँ चल रही. Next. नहीं, ये चलाना नहीं, हो गया, ये खत्म. नेक्स्ट. स्टॉप शेयर कर दूँ. हाँ, ये ये कैंसर का ट्रीटमेंट इस तरह भी होता है इंडिया में. This can only happen in India. And here we are talking of survivals. Now the other part of story, which is actually ground reality. I'm just taking an example, and this is true example. 50-year tobacco chewer laborer has got non-healing ulcer in the mouth for 3 months. He consults an RMP, then a dentist, spends 3 months more in the village. There's lack of awareness. There's no screening. He is not aware of कि तंबाकू से नुकसान क्या होना है. He is referred to a higher center in Delhi from Bihar. He lands up at All India Institute of Medical Sciences, waits for OPD registration. There's no place to stay in Delhi. He is accompanied by 2 relations. With lot of efforts, he is seen by a dental surgeon in dental department, examined, a biopsy is done. He gets the histopathology report in 3 weeks time, and then referred to Indian Rotary Cancer Hospital from there. He gets an appointment for 6 weeks. वो बेचारा बाहर टेंट में बैठा है. He is investigated further. It takes 4 weeks more. He is fixed up for surgery after 5 months. Date for 5 months. More than 1 year has passed. It is given to him in writing, try private hospital. He sells his fortune, sells his land, sells his house, completes treatment. Do you think healthcare is affordable? So these are the problems in healthcare delivery system which impact survival. If he was aware, he could have straight away gone to a tertiary center or a secondary center or a good primary healthcare center and taken proper advice. He has spent more than 1 year taking treatment, and by that time stage 1 becomes stage 4 disease and the poor man dies and sells everything from home, leaving nothing for his family. So if you see the patient perspective, there is no health literacy. He is not aware कि क्या करना है. There is cost of transport, cost of stay, food. He has to adhere to the appointments. He loses job. He has to look after his children. There is no insurance with him. More than 80% of the people in India don't have insurance. Then if you come on to the clinical side, same care is not provided everywhere. And mind you, we are talking of big institutes where residents see these patients. Where is the sympathy? Where is the empathy with these people? How do they behave with the patients? Have you ever seen? Patients get so much demotivated. Poor man who can't afford has to stick on to these places. Investigations and treatments are missed. Today it will be done. He'll be given an appointment for surgery for after 2 months. 2 months he will be told कि तुम्हारी investigation पूरी हो गई, दोबारा से कराओ. He'll get it again. There is weak policy framework and the communication styles are very poor, and I will say pathetic. So the crux of the problem is, I label it as accessibility and affordability. 10 minutes, 10-15 minutes more I'll have. In India, why we are lagging behind is poor accessibility and poor affordability, which gives you poor survival. Access to care means timely use of health services to achieve the best possible health outcomes. There are 6 states, Kerala, Tamil Nadu, Karnataka, Punjab, Mizoram, Assam, which report 18% of the population, but their cancer burden is 23%. So what is happening everywhere is delay in accessing care because of lack of awareness, lack of training of GPs. There's medical shopping. People will go from one place to the other place to the third place. Delay in reaching the expert. There is absence of authentic information. 39% of the people rely on information from GPs or even RMPs. 33% rely on friends and relations. So the actual real information giver is only 1/3. There is inefficiency in hospital processes. 78% patients, they report low satisfaction levels. There are long waiting times. CBC कराना है, 1 हफ्ते बाद रिपोर्ट आएगी. वो रिपोर्ट आ जाएगी 2 दिन में, but the doctor will see him after 1 week. There is lack of effective communication, lack of quality care services. 49% of the patients travel more than 50 kilometers for treatment almost daily. And more than 50% of the patients spend about more than 5 lakh on cancer treatment. And there are gaps in post-treatment care. That's poor guidance. वो डॉक्टर के पास इतना टाइम नहीं होता, उसने 100 पेशेंट देखने हैं, वो कहेगा बाहर वो बात कर लो. उसको कोई चपरासी बता रहा होता है कि कहाँ जाना है, क्या करना है. There's nobody to guide them. There's poor infrastructure and lack of manpower. You see, only 40% of the population has access to comprehensive care centers. We have 475 comprehensive cancer centers, of which 40% are in metros. And at the moment, it is estimated that India needs 800 more surgical oncologists and 2,500 more medical oncologists within 10 years. And we need Linacs, PET scan machines, mammography machines. So how can we improve access? हमारा क्या role है? For doctors, provide and ensure right treatment and right place of treatment. At least guide them properly कि यहाँ जाना है, ये वाली cancer treatment यहाँ हो जाएगी. We should have evidence-based guidelines and care pathways. For the volunteers, help the patients and families navigate with one-to-one assistance. There are many volunteers, many NGOs. They should actually navigate these patients, where to go, what to do, where to stay, how to travel, where to, whom to meet, which NGO to be consulted near the hospital. That is their job. If you are a volunteer, try to help them this way. So what are the efforts of government? Government needs to strengthen public health system, improve infrastructure, add manpower. 40% लोग तो बाहर चले जाते हैं डिग्री हासिल करने के बाद. Evolve cost-effective solutions at all levels in prevention, screening, diagnosis and treatment. Government may increase support to regional cancer centers. Social and economic support mechanisms can be strengthened, and maybe help in stay of travel. I don't know how many of you know that for a cancer patient, they can travel in train free of cost, and one person accompanying gets 50% concession. So that is from government side. There are few stay-in facilities which are free from many of the government hospital side. Aadhaar card, of course, like Aadhaar card, health cards are being issued. Ayushman Bharat digital mission is in vogue, but I think more need to use it. We need to have appropriate referral system, and cancer needs to be seen and addressed as public health priority, and cancer should be a notifiable disease. It is not a notifiable disease till now. That is why we are having so many cancer registries, we have 27 cancer registries in different states, but still cover less than 1% of the population. We are not able to collate our data. The last part is affordability of cancer care. Does it affect survival? भैया पैसा है तो मैं इलाज करूंगा ना. There is high financial loss. See, 74% of the patients do not have any insurance coverage. They compromise on cost of spending on essentials, their food, their rent. They sell their assets, lose their savings. They take loan from landlords. And 66.2% of Indians are pushed below poverty line by healthcare expenditure, especially cancer treatment. And moreover, all the unrealized future goals such as children, education, marriage, they may get derailed. So public policy solutions, everybody heard of the generics. I think there was a lot of opposition without even understanding what will be the implication of generics. Look at the poor man's pocket. He will be benefited with use of generics. I agree, we must address the quality of generics. Insurance must be used as insurance, not entitlement. Reimbursements should be flexible, because even in Ayushman Bharat or CM relief funds, there are restrictions that you can't have PET scan, you can't have this investigation, you can't have robotic surgery or laparoscopic surgery. So I think all this should be made flexible. Incentivize private healthcare system to engage in cancer prevention. So create awareness and focus on prevention and screening programs, because prevention strategies will cost 1/3 the cost of treatment. These are two last slides. I am greatest fan of this man Gautam Khanna, who said in 2017, he is ENY chair at that time, and from the forum of FICCI, he said initiatives have to be categorized for prevention, screening and treatment of each cancer type. At primary prevention front, awareness campaign, stressing on lifestyle habits, food habits, physical activities are necessary. At secondary level, massive screenings with newer technologies have to be done. At tertiary level, the diagnosed patient should have accessibility to the best of healthcare facilities. All stakeholders should create an ecosystem for cancer care accessibility and affordability. These are two important key points. So what is the likely future? It will be screen detection and focus on prevention. That is what can save India. अगर मैं टोबैको को प्रमोट करता रहूँगा और कुछ प्रिवेंशन के लिए नहीं करूँगा, then I think I will see an epidemic of cancer only. We need to have molecular credentialing. I think we are using molecular markers now frequently. Better surgical techniques, maybe gene therapy in next 10 years down the line. Targeted therapies, immunotherapies are being used now more frequently. We may see cancer vaccines for different types of cancers, and we may have someone like Amitabh Bachchan promoting cancer vaccines. We need to have national policies for improving survival. And I think more than 30 years back, I was asked to talk on the future of oncology in India. And this statement I had made at that time: surgeons will be out of job and molecular biologists and IT managers will decide treatment. And this is coming true now. And surgeons and maybe radiation oncologists will phase out slowly. And the last is, we are talking of duration of life. We are talking of survivals should improve. but I think we should also focus on quality of life. And here I am reminded of a line from movie Anand. Thank you.
Sir, it's always a pleasure to listen to you, and it was such an illuminating talk. You hit the crux, the problem of cancer in India, and it is an absolute honor for us to have you deliver this oration. Thank you so much, Dr. Dewan. It was entirely our honor and privilege. Thank you, sir.
I would request our President, sir, to honor our respected Dr. A.K. Dewan, sir, and present a memento for delivering a wonderful oration.
To please honor the chairpersons, Dr. Ashok Agarwal, sir. Dr. Radha Rani Ghosh, ma'am. And Dr. Kamal Singh, sir. Thank you.